Right, wish you all a very good evening. Can you all confirm whether you all can hear me quickly and whether you all can see the screen? Can you all quickly confirm either by
Sir.
unmuting or can hear?
Yes, sir.
Okay, thank you. Right, okay, and you all can see the screen also. Can you all see the screen?
Yes, sir.
Okay, so
Can
we
see.
will so we'll be continuing, and as you all know, this is being recorded, and many of your colleagues will be going through this recorded version, whereas those who are joining live will be, interacting in a live manner, right? Okay. Right. So what we'll do is now, as you can see, this is the session one, and though we call this as a session one, this kind of an orientation session also, right? So in this session, we are going to tell you like what kind of what is our arrangement, okay, for this preparation of this OSCE, and we are going to go through some sample questions, and then how to prepare for that. So that kind of a stuff also we are going to discuss. However, this is not sole orientation. Now there are some uh, technical content also that we will be covering, right? So this session also will be entered into the system, so you all can in future also you all can go through this session, right? So we'll straight away start the session, and if you have any question or anything to ask, I mean, it is not a disturbance. You all can ask those queries, questions, suggestions, right? Clarifications at that time itself, right? Don't wait until the end. Okay, you all can. It's not a disturbance. You all can talk at any time, right? Those who are joining live. I mean, I always promote joining live because then you have the opportunity of getting things clarified, right? Okay, right. So we all know that, I mean, under the new format, we are having this OSCE where 18 station will be there, and two, it is mentioned that two will be on community medicine. But however, it is mentioned that, I mean, some of these stations may be kind of mixed, right? So it is minimum two stations, whereas, I mean, some other stations also may include some of the stuff related to community medicine, right? And when you are thorough with what we are going to discuss, like it will facilitate facing the other stations as well. Okay, so keeping that in mind, right? We'll see what is our plan for this OSCE series. Now, our OSCE series will include 6 sessions, right? Out of those six, now this is the first session. Okay, even though that is this is a orientation session, as I told, I mean, this will cover certain technical things also, right? Okay, and then we are going to, as I told, I mean, for the benefit of those who have just now joined, we are going to put this session into the system, right? So you all can go through this whenever you want also, right? Following this session also, right? And then now after this session, we will do like in this session, we are going to see like some general stuff in relation to OSCEs, and some we are going to refresh the possible areas that may be included in OSCE stations, right? And then in the next 3 sessions, right? We will be covering OSCE stations with sample questions, okay, and answers, okay, in relation to three aspects. Session two, we'll be focusing on maternal and child health related stations, right? Maternal and child health. And then in session three, we'll be discussing about disease control, environmental and occupational health related stations, right? And then session four will include the aspects that are not only related to maternal and child health or disease control, environmental and occupational health, maybe general aspects related to both of these, or maybe certain aspects like, let's say, demography related questions, right? Then non-communicable disease related questions, right, where they may not directly be categorized as maternal and child health or disease control, environmental and occupational health, right? So session three will be covering those other topics, right? And some of these OSCE stations may include some interactive live stations also. So in session 5, we'll be having a communication skills related session. And what we are going to do is we are going to give you some slots, right? We will mention certain time slots, so you can select the time slot that you like, right? So in session 5, we'll be having some kind of interactive session, right? Where the same that it's a live station also, right? And then I mean that you can select the time slot, right? We'll tell you more details about session 5 while we are doing the other sessions, right? And then session 6, right, will be adding some changes that will be done. Okay, so I'll show you in the next slide, like why you should get updated your knowledge on community medicine in the next slide, right? And then likewise, I mean, in community medicine, basically, many changes are happening, right? So that it is a must that you get updated just before the exam also, right? Okay, and then like the recent changes and some timely topics we'll be discussing in session 6. Okay, so if I show you again an example why you should get yourself updated. Now you see that if you listen to radio and television and read newspapers these days, you will hear that a recent amendment has been done, right? So you know that up to now, when someone wants to get sterilization done, either female sterilization or male sterilization, vasectomy or LRT. Okay, LRT is the female sterilization, and vasectomy is the male sterilization method, right? So up to now, there was eligibility criterion where you needed the spouse's consent for that. Okay, you should have the written consent of the spouse also to undergo sterilization up to now, right? But now you know that criterion got amended. Now spouse's consent is not needed. Now your previous batch, okay, when your previous batch was preparing for the OSCE, that spouse's consent was mandatory. Right now, for you all, when you all are facing the OSCE, now spouse's consent is not mandatory. So, see, like even within these several months, few months, there has been a change, right? So that is why you should get your knowledge updated on recent changes and the timely topics, right? So that is why we have added a special session, okay, special session uh, as session 6, where we'll be discussing recent changes and timely topics. Okay. Right. So with that plan, now if I show you some give you more idea. So our session 2 will be on maternal and child health, as you were told. So what we are going to do is, in the system we will be putting a template like this. You can see now this is the template for station 1. Okay. Likewise, there will be several questions, right? So you can see that it will be very comprehensive and a vast area is covered in that, right? So likewise, I mean, station 2 like that, I mean, even though there will be 2 stations in community medicine in your whole OSCE, right? But I mean, these sessions, I mean, we'll be covering many more sample OSCEs, right? So that, I mean, when you go to the OSCE, you all feel prepared and confident, right? So what we are doing is, for each session, we are putting a written template like this, okay? And then there will be some sample OSCEs, projected OSCEs in the system. Like you can see that, I mean, uh, there will be a presentation with these stations. Now, what you should do before the session is, I am telling about the next session, right? Before the next session, you all should go through this presentation and try to complete this template. Okay, template is arranged in such a way that it is congruent with what is shown. You can see that in this station now six pictures are there, right? Now you can see in the written template also. Now some several questions are asked. Like items used in relation to services delivered by MOH officer shown. Answer the following questions, right? Name the items 1, 2, 3, 4, 5, 6, right? Then write one use of each of these items, right? And what is the label highlighted in red in item 1 called? So like that, you can see that there's something highlighted here. Okay. So likewise, there will be several questions and you are expected to write answers for those, right? And then we will put another discussion session, okay? A video, so that you can go through the answers, right? In that discussion, for each station, we'll be like discussing some background details, background theoretical content also, right? So not only the answer, so you can refresh the whole area around. So if a similar question is there, that you can answer that question also, right? So that is our plan. Now, as I told, if I summarize again, we'll be having 6 sessions, right? First session is this session that you all are participating now, and the session that your other colleagues will be witnessing in the system, right? When we put this as the recorded version, now we are having a live session now, but we'll be putting the recorded version into the system, right? And then session 2 will include questions on maternal and child health. Session 3 will include questions on disease control, environment, occupational health. Session 4 will include other topics, and session 5 will be on communication skills, right? And session 6 will be covering changes that will be done and some timely topics in relation to community medicine, right? Okay, then for each session, we will be putting we will be putting questions for every session, and then there's a answer template. Okay, what you can do is get a printout of that answer template, right? And go through the questions shown in the system and write the answers, right? Time and write the answers as if you all are facing a real OSCE, right? And then you all can witness the discussion session on for answers that will be in the system, right? In that discussion section, we will be not only just telling the answers, but we will be discussing around the topics, and like then we will be covering a comprehensive scope there. Okay, so hope that the plan is clear. So is it clear for everyone? Can you all quickly answer? I mean, either by unmuting or by message. Is the plan clear?
Yes, sir.
Okay, right. So if I show you some examples, now our session 3 will include disease control, environmental and occupational health. So there will be questions like this, right? So you can see that some pictures will be shown and some videos will be there. Okay, some scenario will be there like that. And then when we are discussing, we'll be discussing the relevant circulars, relevant background details on that, and relevant theoretical stuff like that. Okay. And then session 4 will include other topics, right? Like non-communicable diseases, demography, like that. Okay, I'm just now showing you just 2 stations, but there will be many questions, right? And then session 5 will include communication skills related sessions. Okay, so like that, where you all are expected to talk in the exam, right? Advising people and describing things. Okay, like that. Okay, so we'll be covering that also. And then the session 6 will include the changes that would be done, that has been done in the previous recent times, and also, I mean, by the time that you will be facing the exam, like in the next following months also, if any change is done in the next few weeks, or if in the next few weeks also, if any change is done, so we'll be discussing those as the last session, as session 6. Okay. So I told one example, sterilization, the consent of the spouse now got changed. So likewise, now you see that if I tell you some more examples, right? Now you see that there was a flooding event recently, right? There was a disaster recently, right? So in relation to disasters, there are some possible OSCEs, like there's something called the traffic light system when we are having a health emergency operation center. Okay, so in the session 6, we'll be covering those things also, right? And then questions regarding disaster management plans or emergency response plans. What is the role of the health sector? If someone asks you what is the contribution made by the medical officer of health when there's a disaster, then you should have an answer to tell, right? Okay. And then, like after the disaster, you chlorinate the wells, right? So there's a formula to chlorinate the wells, and what are the components in there, like what you use for chlorination of the wells. And then regarding doxycycline, in disaster situations to prevent leptospirosis, we give doxycycline, right? And what's the difference in the method that we give doxycycline in disaster conditions compared to when we give that to farmers, right? And what are the side effects of doxycycline, and what are the advices we give the people? How long should they get doxycycline? Okay, so like that, we'll be discussing all these things, right? And then there's something called TCL, tropical chlorinated lime. Okay, we use as a disinfectant. So regarding how to prepare this and how to use this following the disaster situation, right? So all these things, I am telling you some timely topics that we'll be discussing in the session 6. And in addition to these timely topics, we'll be discussing any changes that would be done in the next few weeks also, right? Like in the case of this spouse's consent for sterilization. So I hope the plan is clear, right? So it will be a very comprehensive set of series, right? And then you all will feel confident, and you can ask from people who sat for the exam last time also. So like, I mean, they were happy like when they were facing the exam, and then from the feedback, like, I mean, that they did that well. Right. So now now this is not only an orientation, we are covering some technical things also today. Like we'll be adding this session into the system, right? So now we will move into some technical stuff, right? I want to summarize some domains that the questions may come as OSCEs, right? So that when you go through this session, now it will be kind of a background refresher for you all to get the maximum out of the following sessions, right? Okay, so with that, we will move into that summarization or refreshing the content, right? But before that, I mean, let me tell you, like, I mean, now in this session as well as in the following sessions, we'll be discussing some theoretical concepts, right? You know that in our system, there's a theories series also, right? Anyhow, in this also, we'll be covering the relevant theoretical inputs for you all to refresh, right? But if someone wants to get more input on theory, then you all can join that theory series, right? But if you all have already gone through that, right? I mean, in this series also, we'll be discussing some theoretical content as well, right? That is relevant for those questions. Right. So let's start this summarization with topics related to maternal and child health, right? So you know that when we get vaccination, right, we can divide vaccination. I mean, we give vaccination to ensure that people have immunity, right? Immunity, right? So immunity can be divided into two: active immunity and passive immunity, right? Active immunity is where antibodies are formed within bodies of people, right? Passive immunity is where when we transfuse antibodies from outside, right? Then active immunity can be further divided as natural and artificial. Passive immunity also as natural and artificial, right? So one example of active natural immunity is where following a natural infection, the immunity we get is active natural, because you know it's actively the antibodies are formed within the body of the person, and it's a natural process. So active natural, right? Vaccination is an example of active artificial, right? It's not a natural process, but antibodies are formed within the body, but it's an artificial process, a man-created process, right? So all vaccinations are examples of active artificial immunity. Then mother to fetus transfer of antibodies is an example of passive natural, right? Where antibodies are transferred from outside to the fetus, but it's a natural process. So passive natural, right? And in some certain instances, like let's say Guillain-Barre syndrome and then COVID-19, then we need to transfuse antibodies from outside, right? Antibodies from outside. So that is an example of passive artificial, right? So this is one area like that you should know when you are going for skis, the type, how to categorize types of immunity, right? And then the Sri Lankan EPI schedule you should know in and out, right? So you know that we start with the BCG, and 2 months, 4 months, 6 months, we give 3 pentavalent doses with 3 oral polio doses and fractional IPV. Now, mind you that from next year, there will be a change in this fractional IPV. Okay, so still the circular, I mean, we'll be discussing that when we are doing the session 6, right? So that change would be made by the time that you all, before you all go to the exam, so that we will cover in the session 6. So currently we give 2 doses of fractional IPV at 2 months, one at 2 months and the other one at 4 months, right? And then 6 months, we give third dose of pentavalent with third dose of oral polio. Then 9 months, we give first dose of MMR. MMR stands for measles, mumps, rubella. Then 1 year, we give Japanese encephalitis, right? And then 18 months, fourth dose of DPT. Why we say fourth dose of DPT? Because you see that pentavalent also include diphtheria, pertussis, and tetanus, right? So this is fourth dose, right? Then fourth dose of OPV. 3 years we give second dose of MMR, and then 5 years we give DT. You see that there's no pertussis, right? And then fifth dose of oral polio also there. And then grade 6 for girls, we give HPV 2 doses 6 months apart. Grade 7, we give ATD for both girls and boys. And then in pregnancy, we give tetanus toxoid. So you know the way that the way that we give tetanus toxoid, there's a difference. A person who has already got 6 doses of tetanus by uh, let's say grade 7. Now, let's say pentavalent include tetanus, right? So 3 doses of tetanus are there by 6 months, right? And then DPT include tetanus, so 4 doses. And then DT include tetanus, 5 doses. ATD include tetanus, 6 doses. So someone who has got 6 doses of tetanus by grade 7, if that one is a girl, and if that girls become pregnant in the next 10 years, within the next 10 years, no need to give a tetanus dose in pregnancy, right? If that one becomes pregnant after 10 years, then we give 1 dose as the booster dose, right? Okay, so likewise, for pregnant mothers, the schedule of tetanus depends on whether that one had got 6 doses of tetanus previously or not. So those things we'll be covering in the this maternal and child health session, right? That is the session number 2 of this OSCEs, right? So now I am just summarizing, right? So these things will be more in more detail will be covered in the next sessions, right? And then when we get types of vaccines, right? There are vaccines that are given in the form of injections, and uh, orally, like in the case of oral polio, right? So you should know what vaccine is given in what form, right? And then we categorize vaccines as live attenuated versus killed vaccines, heat sensitive versus cold sensitive, and liquid versus freeze dried. Freeze dried means those are given in the powder form, right? That comes in the powder form. So there's a diluent also coming in the vaccine. So we use that diluent and reconstitute the vaccine, right? When we are giving that is a liquid, anyhow, the vaccine comes from the manufacturer as a powder in freeze-dried vaccines, right? So you should know what are the freeze-dried vaccines and what are the liquid vaccines, okay? So those will be covered. And then live vaccines, again, we can categorize as live bacteria like BCG, and live viral like oral polio, measles, mumps, rubella, that is MMR and JE, right? And then killed vaccines are categorized into further 5 types: whole cell, subunit, toxoid, recombinant, conjugate, right? So likewise, you can see that, I mean, they can give any vaccine vial as OSCE station and ask you whether this is a live vaccine or killed, and whether this is heat sensitive, cold sensitive, or comes as liquid or freeze dried, right? And at what time period of the child's age that we are giving this vaccine, okay? So those kind of questions can be asked, right? And then vaccines we store in the MOH offices in the special refrigerator called ice liner, right? So that we have covered in the theory session also, and then in the next sessions also it will be covered, right? Then there's something called open vial policy. That means when multi-dose liquid vaccines are opened, right, they can be used for next 28 days, right? Provided that expiry date is not met within that 28 days, and that they are used first, and they are stored separately. Okay. Right. So, if I tell you some few more, areas that can be asked. So, you know that in our EPI schedule, except for HPV vaccine, many other vaccines come in multi-doses in one vial. Uh, that the volume that is in one vial is there not only for one child. Okay, many doses can be obtained from that. Some vials, let's say 5 doses, some vials 10 doses, okay, some vials 25 doses, like that. Okay, so that is why they are called multi-dose. So when multi-dose liquid vaccines, they can be kept for further 28 days. When we open that is called open vial policy, right? Whereas that other ones, that the live vaccines that we reconstitute on that day, can be kept for either 6 hours or until the end of that clinic only, right? And then there's this vaccine carrier, where you can see the lower one, that is the one that is recommended now. This is called freeze protective. You can see that ice packs are not touching the vaccine vials, right? So you can see the middle one, ice packs are there, vials are put in the middle. So that some of the vials may touch the ice pack. But you see in the new one, when the vaccine vials are put in the middle, they are not touching the ice packs, right? So that this is the type that is used. Can you all see my cursor moving? Can you all see the cursor? So respond either verbally or as a message. Can you all see my cursor?
We can see, sir.
Okay, right. So this is the type of the vaccine that vaccine carrier that is recommended that use now, right? Okay, right. You know that. I mean, if you ask from your colleagues, you see that. I mean, this vaccination is a hot topic in OSCEs, right? Okay, and the site. What are the sites that we give vaccine? So you know that the deltoid muscle mass is powerful enough by 1 year, only by 1 year in children, right? So if you want to give an IM vaccine, intramuscular vaccine, we don't give to deltoid below 1 year, right? So to the contrary, we have to go to the thigh, right? So that is why penta vaccines we want to give as IM. So that is why 2 months, 4 months, 6 months, penta doses that we are giving to the thigh, right? But after 1 year, if you want to give a IM vaccine, then we can give to the deltoid. After 1 year, we can give, right? So, vaccines can be given to thigh, deltoid. Okay, when we are giving to the thigh, we are giving to the anterolateral aspect of the thigh. Now, again, I'm stressing that I'm just summarizing and I'm just refreshing and, just polishing what you already know. These will be in more detail, will be discussed in the following sessions, right? And if you want further additional knowledge, you can go through the theory session again. If not, like I mean, anyhow, these will be covered when we are discussing the questions in the next sessions, right? And then when we are giving IM injection, intramuscular injection, the needle has to go through a longer distance so that we have longer needle for IM, right? And we give that 90 degrees, right? And then subcutaneous, we have a little shorter than the IM and we give 45 degrees. And the intradermal, we have the shortest needle, right? And then we give the vaccine to the skin layer, right? So when we are injecting the vaccine to the muscle layer, that is called IM. When we are injecting the muscle to the below the skin, it is called subcutaneous. And when we are injecting the vaccine into the skin layer, that is called intradermal. So BCG and fractional IPV are given as intradermal. Okay, right. So you see that EPI schedule again, can see. And then oral polio and IPV, you need to differentiate those two. I mean, you should know. So oral polio is a live vaccine. Fractional IPV is a killed vaccine, right? Oral polio protects uh, that IPV, fractional IPV protects that person but does not protect the community. Oral polio protects that person as well as the community because there's something called gut immunity, right? So those things we'll be discussing in that in the sessions, right? And then when we give the vaccine, why we give the vaccine? We want to prevent a disease from occurring, right? But vaccines may give rise to some unwanted effects, untowards, undesirable effects, which are called adverse events following immunization, AEFI, right? So AEFI, we can categorize it to 5 types, okay? Vaccine product related, like anaphylaxis, vaccine quality defect related, like in the case where temperature is not maintained and the vaccine quality is low, and then immunization error related, like IEM vaccine we have if we give as subcutaneous, or where we should give to the that deltoid that has been given to another area, okay, because of an error. So that kind of a thing is called immunization error, right? And then coincidental, that means even though we have an unwanted effect that is not related to the vaccine. So it will be evident only later, but the investigation will be done, right? And then immunization anxiety related. Okay. Okay, so like that, we can categorize this AEFI into several types, right? And then there are several forms that we use to send AEFI related data, right? For every month, all MOH areas send that in their area, how many adverse events following immunization have been reported. Okay, and AEFI, all AEFI should be reported, right? but all need not be investigated. Like this mild allergic reactions, arthralgia, high fever should be reported, but need not be investigated, right? And there are certain forms called AEFI form 1, 2, 3 that will be used in reporting these that we will discuss in the next sessions, right? And that we have discussed in the theory sessions also, right? And then you need to know, I mean, in an OSCE station, if they ask that we give the vaccine, then suddenly the child falls, right? Now you need to differentiate whether this is anaphylaxis or whether this is a mere faintish attack, right? Then you know anaphylaxis is there when the signs that are suggestive of anaphylaxis are tachycardia with weak carotid pulse, whereas in faintish attack it will be mostly bradycardia with pulse not being weak. Okay, and then the hypotension will not be reversed in anaphylaxis, right? And then skin will have a erythematous appearance in anaphylaxis, right? Whereas there will be pallor-like skin manifestations in faintishness, right? And respiratory system is more affected in anaphylaxis. Okay, so like that, you need to know to differentiate anaphylaxis from the faintish attack, right? Then you should know in and out about the shake test, right? So shake test we do to identify when we are to identify any frozen vial, because you know that we should keep the vaccines between +2 to +8, right? So by a mistake, if a vaccine has been frozen, we need to identify that, right? So there's a procedure that we call as the shake test. So you know that. So we get the suspected vial and then we compare that with a deliberately frozen vial. So the deliberately frozen vial will look like this. See, my cursor is moving, right? So if your suspected vial is also having an appearance like this deliberate frozen vial, then we can conclude that most probably it has been frozen, right? So we do not use that. So that is called shake test, right? Then cold chain means all the people, processes, and equipment involved in maintaining the potency of the vaccine from the time of manufacturing up to the vaccination. Then there are certain equipment, people, and processes that are involved in cold chain maintenance, right? So you can see that there one example is called vaccine vial monitor. You can see there's a circle, and within the circle there's a square, right? So you know that there can be 4 stages depending on the color of this circle and the square, right? So you see that in the first one, the color of the square, right, is lighter than the color of the outer circle. So that is called stage 1. In the second stage, still the color of the square is lighter than the outer circle, but you can see it little bit darker than the stage 1. But still, it can be used. Stage 2. When the colors match in intensity, that is called stage 3, we don't use that. Stage 4 is where the square is having a darker color than the outer circle. We are not using that in stage 3 or 4. So this is another hot area where questions can come, right? So they can show you some vials in stage 1, 2, 3, or 4, right? And then you need to identify, you need to tell what is the stage, right? So now you know the rationale, right? Okay, then oral polio, when we get oral polio vaccine, before 2016, oral polio included 3 polio virus types. Okay, 1, 2, 3. So that is called trivalent polio. Right, but now after 2016, the type that the oral polio that we are having include only 1 and 3. Why? This type 2 is more associated with vaccine-derived polio, right? Okay, so we want to prevent the wild polio as well as the vaccine-derived polio. Okay, because of that, what we have done is, since the second strain is more associated with this vaccine-derived polio, we have removed the second strain, and now the oral polio that we are having is including 1 and 3, right? Because we are having IPV also, fractional IPV also. Now, it and this oral polio both collectively cover the immunity against all 3 strains. So the oral polio does not include strain 2. So that also you should know, right? The change that happened, this change is called the switch. Okay, switch is where trivalent polio was made into bivalent polio, right? Then school medical inspection, you know that school medical inspection, all the MOH areas are supposed to care for the health of the school children who are in the schools within their area. Okay, so there's something called school medical inspection where children are physically examined. Okay, and it is encouraged to examine the teachers also if there's a need, right? So few days before the allocated day, the PHI and the relevant other staff members will go and examine the non-medical examination components. Like you see that they can check the vision, they can check the weight, height. Okay. So like that, I mean certain things that they can examine and document. And on the day of the school medical examination, the team will go, the full team will go, including doctors. So when the doctor is there, they can examine the full, systemic examination, including cardiovascular system and respiratory system, like that. Okay. Okay, so you know that, I mean, some of the examinations that can be done by non-medical people like public health inspector would be done few days before the SMI or school medical inspection. And on the day of the school medical inspection, the cardiovascular system, respiratory system, and all other relevant examinations will be done. And the needy children will be identified and referred. Okay. Right. And then there are certain services that we give in relation to school medical inspection. We give iron tablet, weekly iron tablet. Okay. 24 weeks for 24 weeks, like weekly dose for 24 weeks. That is for 6 months for all the children, grade 1 to 13. Right. So you know that. Okay. So that is again an area that is frequently asked in those keys. Right. And there are certain forms that we used in this SMI called a referral form, then student health record, like that. So you need to identify those, right? So those will be covered in the coming sessions, right? And then relevant health education sessions will be done. And you know that for girls, grade 6, HPV 2 doses will be given 6 months apart. And for boys and girls both, ATD vaccine is given at grade 7, right? And then we have already done what are the leading cancers in Sri Lanka, right? Okay, so then the latest ones you should know, and the latest version will be covering in the last session, because you know where we are doing we doing the changes that are done. Okay, so anyhow, you know that in well women clinics we target breast cancer as well as the cervical cancer, right? So this well women clinic is again another hot topic that is covered in OSCEs, right? So you know that in well women clinics we screen for 4 diseases: diabetes, hypertension, cervical abnormalities including cancer, breast abnormalities including cancer, and the 4 diseases are those. And then we screen for high BMI, which is a risk factor. So 4 diseases and 1 risk factor, right? So you know already how we are screening for those. So you know that when we are getting the pap smear. So this is called the Cusco bivalve self-retaining speculum and Ayer spatula, Ayer wooden spatula, glass slide, right? Coupling jar. Okay. So what we do is we insert the speculum, right? And there's a light source. And then we insert the Ayer spatula, rotate 360 degrees, get the smear and apply on the glass slide and fix in the alcohol in the coupling jar, and then fix in the air also, and then send for cytoscreeners, right? Okay. And then we have growth charts. Again, now if you ask from your seniors also, I mean, we'll be doing in and out about growth charts. We have done also, and we'll be doing in the sessions also. Many of the OSCEs are there. Sample OSCEs are there on growth charts. Okay. And you should know what are these color zones and all. So you know this is an example of a growth chart. This is the weight for age chart, right? And okay, so we have weight for age charts after 2 years. Then again wait for HRs from 3 to 5 years. Okay. And then height for age chart up to 5 years. And in the same graph, we are having occipitofrontal circumference for age chart up to 3 years. And OFC, you know, we measure when there's a need. We don't routinely measure. When there's a need, only we measure, right? And then we have weight for height charts, right? Weight for height chart. So height we measure after 2 years. After 2 years, what we measure is the length. So we have weight for length chart after 2 years and weight for height charts from 2 to 5 years, right? And then from this weight for age chart, when the weight for age is less than -2 standard deviation, we call that as underweight, right? And underweight again further categorized as moderate underweight and severe underweight. So all the things will be done in the coming sessions. Okay. And we have done in the theory sessions also, and will be touched in the coming sessions also, right? And then when the length or height is less than -2 standard deviation, we call that as stunting. So when it is between -2 to -3, it is moderate stunting, and less than -3 is severe stunting. So likewise, the previous weight for age also, when it is between -2 to -3, is called moderate underweight, and less than -3 is called severe underweight, right? And then weight for length or height also, when it is -2 to -3 is called moderate wasting, and when it is less than -3 is called severe wasting, right? So you see growth charts also another hot area that may come for any OSCE, right? You may be asked, there may be a growth pattern, and you may be asked to describe the pattern, and then what zone the child's growth is there. You need to give a name, whether that is moderate stunting, moderate wasting, or what, right? Okay. So like that, growth charts you should know in and out to interpret, and there will be plenty of questions on those, right? So these color zones again, if we summarize, less than -3, severe underweight in weight for age chart. Moderate underweight is orange. Risk of underweight is -1 to -2. Still that is normal range, right? Light green zone also normal range, but we give another specific name for that called risk of underweight, right? So similarly, risk of stunting. Okay, similarly, risk of wasting, right? Okay, and then anyhow, -2 to -3 is normal range, right? And more than +2, we may call risk of overweight and obesity in the weight for age chart, whereas we don't call that as overweight obesity, right? Just we say risk of overweight and obesity. Whether it is overweight or obesity, we should get from the weight for length, that weight for length or weight for height chart, right? It's only from these charts that we can detect overweight and obesity, not from the weight for age chart, right? So we have stressed that in the theory sessions, and also in these sessions also we are talking about that. And for school children, there are two graphs. So one is the height for age chart, right? Height for age chart, and then BMI for age chart. Okay, so BMI for age chart we used to detect wasting, right? And there's a difference in the way that we interpret, right? So in a child less than 5 years, okay, in a child less than 5 years, we call the child as overweight and obesity when the child's weight for length or weight for height is more than +2, right? +2 to +3 uh, overweight, and more than +3 obese, right? Anyhow, +2 is the cutoff. But you can see in school children, you can see this graph, okay? It is more than +1 is the cutoff, right? +1 is the cutoff to detect overweight, right? So are the things clear up to now? Can you all respond? Are the things clear? Quickly, as verbally, or I mean as a message, tell whether the things are clear up to now.
Yes, sir.
Okay, right. And then there's a particular frequency that we measure weight or height. So we know that occipitofrontal circumference we measure at birth and then when necessary. Weight we measure once a month for 2 years, and once in 3 months after 2 years. That is up to 5 years we measure once in 3 months after 2 years. But if there's growth faltering, we measure monthly. Length we measure birth, then 4 months, 9 months, 12 months, 18 months. Okay. And the height we measure from 2 years onwards every 6 monthly. 2 years, 2.5 years, 3 years, like that. Okay. But if there's a growth faltering, the length is measured once in 2 months and the height is measured once in 3 months. Right. So what is growth faltering? You know, growth faltering is when we get two successive measurements. For an example, let's say weight for age. If we get two successive measurements, if I show you with let's say my whiteboard. And now let's say that there's a growth curve like that. This is the, let's say this is 4 months and 5 months. If the child's weight was here, right? Then at 5 months, we expect the weight to be here, right? That is the place where we expect the weight to be. But if the weight is somewhere here, then that is called weight loss. If the weight is at the same weight, then it goes same weight, right? Weight is bit increase, but not up to the expected level. So that is C. That is called inadequate weight gain. Okay. So weight loss, same weight, inadequate weight gain. All three are termed as growth faltering, right? That is called growth faltering. Okay. So let us move to the presentation again. Can you all see the PowerPoint again? Can you all see the PowerPoint?
Yes, sir.
Okay, right. Okay, so then another hot area that in OSCE is that the questions can come is the frequency of growth monitoring, right? When a child can be given and the age can be mentioned and can be asked like when will be the next monitoring of the weight, when will the next length monitoring be, like that, right? Okay, then the instruments. So you see this is called infant beam balance. This is used up to 6 months. This is called spring balance. Okay, used after 6 months. Okay. Okay, this is called adult beam balance. Okay. Or that some people call bathroom scale. Okay, adult weighing scale. By different names we can say. So this is used when the child can keep the legs steadily, right? Okay, length is measured by either by infundometer or length measuring board, right? Height is measured by height measuring rod or stadiometer. Okay, right. And then you have child health developmental record, right? Child health developmental record, you all know two colors are there, right? The blue color is for boys, right? And the pink is for girls, right? So you know that when you get the two CHDRs, the content is almost the same. I mean, the things that will be there in almost the same. So minor variations will be the cutoffs of the growth charts will be different, right? Girls different, boys different. So it is very important that we use the correct format. Girls growth charts for girls, boys for boys. Because you know the growth spurt and all are different. Onset is different between girls and boys, right? So if you plot the growth of a boy with the girls CHDR, then you might get incorrect interpretations. Okay, so it is important to use the correct format, right? And except for the cutoffs, and also you know HPV vaccine is given for girls, right? Okay, so most of the other things are same in boys and girls, right? Right, and then we know how the nomenclature changes. Underweight is reduced weight for age, stunting is reduced length or height for age, wasting is reduced weight for length or weight for height, right? This wasting is divided into moderate wasting, which is called moderate acute malnutrition, and then severe wasting, which is called severe acute malnutrition, right? SAM. So SAM is severe wasting. So when a child is detected as SAM, we refer the child to the pediatric clinic, right? So in the pediatric clinic, the child will be examined. If there are complications, the child is admitted. If not, child is not admitted but managed as an outpatient. Okay, and the child will be given high density that biscuits like BP100. So you all know that, right? Okay, and any changes that are done, we'll be discussing in the final session, right? And then when a maternal death happens, there's something called 3 delay model that you should know whether there's delay 1, delay 2, or delay 3. So delay 1 is called delay of seeking medical care. Delay 2 is called delay of reaching medical care. Delay 3 is delay of receiving quality medical care, right? Okay. So likewise, you need to categorize whether that is delay 1 or 2 or 3, right? So that is again, a scenario can be given and you can be asked what are the delays that are there, right? So we'll be practicing those when in the coming sessions, right? And then you need to know what are the difference between breast milk and the formula milk, right? So you should know that breast milk is high in energy, high in fat, high in protein, and calcium to phosphorus ratio is ideal in breast milk, right? Sodium content is low, which is better, right? Because infant's kidney is not mature enough to handle too much sodium. That is why we don't give salt to the infant. Remember, we don't give salt to the infant, right? Okay. And iron, when you get iron, iron may be higher in the formula milk, but the absorption is high in the breast milk, right? Okay. And then there can be questions on positioning, right? Signs of proper attachment of the child when the child is being breastfed, right? Okay, so all these things we have already discussed and also will be discussing, right? And then complementary feeding. So complementary feeding we do, and after 6 months, in addition to breast milk, we give other food also, which is called complementary feeding, right? So complementary feeding, there can be many questions, right? The period 6 months to 2 years, we can divide into three: 7 to 8 months, 9 to 12 months, and second year of life, right? Okay, you can see that we can differentiate these three phases as main meals. So in the 7 to 8 months, we give 2 to 3 main meals, whereas 9 to 12, we give 3 to 4 main meals, right? So like that. And amount of main meal also, in the 7 to 8 months, one main meal is about half a cup. Cup means 200 milliliters, right? And 9 to 12, one main meal should be equal to 3/4 of a cup, right? And in the second year, just a little more than 1 cup, right? And snacks are the things that we give in between main meals. So we just give 1 to 2 snacks, right? And texture also, in the first phase, we give smash food, and in the second phase, chopped or hand-picked food. And from the second year onwards, we can give family food to the child, right? Okay, so then you should know that, I mean, until 6 months, we give exclusive breastfeeding. Even water we don't give in the first 6 months, right? But after 6 months, breast milk is not enough, right? So after 6 months, we have to give other food, and without interfering with these other main meals, we continue giving breastfeeding, right? Okay, and the difference between kwashiorkor and marasmus. Okay, you should know that kwashiorkor is specific protein energy malnutrition, right? Specific deficiency of intake of protein, whereas marasmus is general energy intake deficiency, right? Okay, so both are going under undernutrition, and underweight, wasting, and stunting also go under undernutrition, right? So when you say overnutrition, what are the two terms we use? Overweight and obesity. So we have discussed about those, right? And if they give a scenario where two children, one child having scaly skin changes, change in the color of the hair, and ascites, features of ascites like distorted abdomen and swollen ankles, so those are features of kwashiorkor, right? And if the child is having old man's appearance, wrinkled, right, skin, hair loss, old person's face, muscle wasting, so those are signs of marasmus, right? Okay. Then vitamin A, when there's vitamin A deficiency, there's bitter spots, serophthalmia, and keratomalacia, right? That we have discussed. So you should know what are those, right? And then vitamin A deficiency, for the prevention of vitamin A deficiency, we are having a vitamin A megadose program, right? We give every 6 months, 6 months, 1 year, 1.5 years, 2 years, 2.5, 3 years, 3.5, 4, 4.5, and 5. We give one megadose, vitamin A megadose to children, right? And for mothers after delivery, we give 2 megadoses of vitamin A, right? So that is called vitamin A megadose program. But anyhow, you should know that, I mean, the best method of that addressing vitamin A deficiency is dietary modification, right? So we should advise the public on what are the food items that are rich in vitamin A, right? So as I told, this is that vitamin A megadose program. Okay, so there can be many questions, like they can show a picture of a child given vitamin A, right? And then ask questions on vitamin A, right? And then iron deficiency, you all know. Iron can be divided as heme iron and non-heme. You know that heme is of animal origin, non-heme of plant origin. So heme is better absorbed than non-heme, right? And then we have triposure. We have a certain type of triposure for mothers, pregnant mothers, that we give 2 packets for every pregnant mother per month. And then for needy children, we give children's triposure, right? So in children's Triposha, picture of a child is there in the Triposha pack, and Triposha that we give to the mothers, there's a mother's photo, right? And then family planning methods, another hot topic that comes for OSCEs, right? So family planning contraceptive methods we can categorize as modern versus natural or traditional, male versus female, hormonal versus non-hormonal, and temporary versus permanent. So you know OCP should know in and out what are the hormones there, right? Okay, and then what to do when a pill is missed. So that part we are covering when we are doing that communication skills session, right? And then condom, we have male condom and we have female condom also, but in the national program, I mean, we from the MOH offices, we give male condom, right? And then DMPA, in the private sector, they can have female condom also, right? So DMPA, okay, that we give 3 monthly, and then subdermal implants, the two-rod variety is called the Jadel and one-rod variety is called the Implanon, right? And then copper IUCD, active for 10 years, right? This Jadel for 5 years and Implanon for 3 years. DMPA for 3 months. Okay, condom, is for one activity, one episode. OCP, provided that 7 pills have been taken previously, is active for the next 24 hours, right? Okay, sterilization, permanent. These are permanent, right? So there are some criteria to be fulfilled in doing sterilization. If someone is more than 26 years and having 3 children, then can undergo sterilization anytime. If more than 26 years and having 2 children, the second child should be more than 2 years. And if less than 26 years, it is done only with medical recommendation, right? Okay. And you should know that. I mean, previously there was another requirement where partners' consent is needed, but now we told that it was amended recently. There's something called WHO eligibility criteria wheel, okay, where we have an outer circle and inner circle, and then we can rotate the inner circle on the outer circle, and then it will display 4 categories, okay, for different disease conditions. So when in front of a particular method, it is mentioned as category 1 or 2, we can use that. One is can use the method in any circumstances. 2 is where the method can generally be used. 3 is used where no other alternative is available. And 4 is where it is contraindicated, right? Okay, and then you should know that the postpartum postnatal care related services. We give postnatal care in the hospital as well as in the field, right? So in the hospital, we monitor for postpartum hemorrhage, we do the neonatal examination, establish the breastfeeding and register the birth, okay, issue the CHDR, so CHDR issued at the hospital, right? And fill the pregnancy, in the pregnancy record, 2 pages are there that will be completed after delivery, right? And then BCG vaccination, vitamin A megadose to the mother, right? Rubella to the mother if it has not been given, and heel prick blood of the baby for congenital hypothyroidism screening, right? And we told in the theory series that we examine now for any hearing defect and congenital heart diseases also. So 3 main conditions are covered, right? In addition to the general examination, right? We are screening for congenital hypothyroidism. We are screening for congenital heart diseases. We are screening for deafness, right? Okay. And when we say field visits, I mean, after the child is going home, child goes home with the mother after hospital discharge, the public health midwife will do 4 home visits, right? First one within first 5 days, second one 6 to 10 days, third one 13 to 21 days, fourth one around 42 days, right? And in between the third and the fourth, at 1 month from the delivery, both the mother and the child will come to the postnatal clinic, right? Postnatal clinic. So in the postnatal clinic, one activity that we do is we screen the mother for postnatal depression using this Edinburgh postnatal depression scale. Okay, so this also is a hot area that may come to as an OSCE. So there are 10 questions, right? Maximum marks that can be allocated for one question is 3 marks. So the maximum marks that can be allocated for this tool is 30 marks. And out of 30, if there are 9 or more marks, right, the mother will be referred for further evaluation. And even if the total is not 9, if there is non-zero answer for last question. Last question is about whether there's any suicidal or self-harm ideation, right? So if it is not zero for that one, irrespective of the total, we refer, right? And irrespective of the marks, right? If we see that the behavior is abnormal, anyhow, we may refer the mother, right? So this is generally used at 1 month postnatal clinic, whereas if necessary, it can be used in earlier hospital, earlier home visits also, right? And for all children, when they are at 6 months, 12 months, and 18 months, we give multiple micronutrient sachets, 60 sachets, right? One sachet per day, okay, mixed with food and given to the child, and then we will have OSCE stations on that. So then you should know in and out about this Jeevani oral rehydration solution also. So we'll be covering some questions on that also in the next sessions, right? And then when we get eligible woman, every midwife is having something called eligible family register, right? So you should know what is eligible family, right? So eligible families there are 5 types. Where there is a woman of 15 to 49 married, then that is called type A eligible family, right? Where there's an unmarried pregnant woman, type B eligibility family, right? Then even if there's parents are not there, if there's a child less than 5 years, then again eligible family, right? And if there's a couple in union and if the female's age is less than 15, that is again eligible family, right? And between 1549, any widowed, divorced, or separated woman, again, that is eligible family. So, like that, every midwife is having a list of eligible families under her area, right? And when a couple gets married, so the newly married couple is getting a package of services from the MOH office, right? So they will be invited through an invitation card. So that can be shown in the OSCE, right? Okay, invitation card for the newly married couple. Okay, and we get the help of marriage registrars also. You know, people get married in front of the marriage registrar, right? So we have a collaboration with the marriage registrar. Okay, and we are keeping some invitations with the marriage registrar, and they will be giving these invitation cards to the newly married couples. And that card will tell that you who are eligible to get some services, please go and talk to your public health midwife, right? So they will be asked to come for 2 sessions, right? In these sessions, they will get some health education inputs and some examinations, some investigations also, right? Okay. So all will be a package there. That will be a package of services for them. Then there can be OSCE stations on pregnancy period also, right? So you should know that pregnancy we categorize into 3 trimesters. Until the end of the 12 week is the first trimester, then 13 to 28 is the second, and after 28, that is from 29 up to delivery is the third trimester, right? So you should know certain events, okay, that are in relation to these trimesters. And in Sri Lanka, we have something called the shared care model where every pregnant mother is looked after by the MOH office as well as the hospital, right? Then, in detecting the pregnancy, urine SCG, if 2 lines are there, we are suspecting pregnancy, right? Okay. And then all pregnant mothers we categorize into 2, low risk mothers and high risk mothers. High risk mothers get more frequent clinic visits and home visits, right? And there's a particular sequence of clinic visits that they are expected to get. 9 to 11 visits per mother, low risk mothers, high risk mothers, depending on the risk conditions, right? More visits will be there. And in clinics, we examine for palo, then edema, right? Then we measure blood pressure, right? We know in pregnancy that in the early periods, the systolic and diastolic blood pressures will go down, but closer to the delivery, again, they will come to the normal levels, right? And then symphysiofundal height we measure, right? Okay, lower pole, upper pole, okay, and the sides, right? And then we auscultate the fetal heart sound using this Pinard stethoscope, right? Okay, Pinard fetal stethoscope, right? And in the pregnancy record, there are 8 pages, and we told 2 pages are there for postnatal period, right? And then certain supplements we give. So changes we'll be discussing in the last session. There's something called multiple micronutrients that we give for non-anemic mothers now. So those things we'll be discussing in the final 6th session in the changes section, right? So you can see the services we can divide into trimesters, right? CHDR we discussed. And in the CHDR, you can see that there's a vaccination page, right? And many of the children when they come for vaccination, they are attending a child welfare clinic also. That means child is also examined, not only the vaccination, right? You can see this child welfare clinic schedule coincide with the vaccination schedule mostly. Only differences are at 1 month, no vaccine, but child comes there with the mother to the postnatal clinic. At 4 years, no vaccine, but the child comes, right? All other time periods when the child comes for this child welfare clinic, vaccination is also there, right? So child will be examined before giving the vaccine in child welfare clinics, right? Right, and we told that there are two graphs, right? And then we know that both pregnancy record and the CHDR, there's a part B also, right? Pregnancy record also, there's something called part B. In the CHDR also part B. Part A is the one that is kept with the family, right? Part B is kept with the midwife. Okay, right. So multiple micronutrients we discuss, right? Then if you move into disease control, environmental and occupational health, a hot topic, a hot area is this notification, right? So there are some diseases called notifiable diseases. So there are two groups of notifiable diseases, group A and group B, right? So we know group A, cholera, yellow fever, and plague are there as group A, and other diseases that you see are there as group B, right? So when a doctor meets a patient suspected as having any of these conditions, they should initiate a process called notification by filling a form called H544, right? And that will go to the relevant MOH area, and that will be given to the relevant PHI, public health inspector. Public health inspector investigate the case and then fill a form called 411, right? And then for confirmed cases, another form is filled, which is called 411A, right? And then 411A and WRCD, that is weekly return, are sent to the now sent through an electronic system, okay, to epidemiology unit, provincial level, district level, okay, and then combining all WRCDs, a weekly epidemiological report is prepared by the epidemiology unit once a week, right? Then dengue control, you should know in and out. Okay, we know the life cycle of the mosquito takes 7 to 10 days only. So that is why we should inspect for breeding places once a week. Okay, for dengue, right? And there are dengue control methods. Okay, so one method is, we have to prevent laying eggs. That is called source reduction. We remove the potential water collection places. That is called source reduction, right? And when there is larvae, we use larvicidal methods. There are biological methods, chemical methods, right? And then adult mosquito, there's something called fogging, right? Fogging, duma gahanawa කියලා කියන්නේ, right? Fogging, right? And then to prevent the mosquito human contact, we have repellents, then mosquito nets, like that. Okay, so like that, you see that there are many methods. And then the ideal method will depend uh, on the circumstances, right? So there may be instances where we need this method, that method, like that. Okay, for an example, if there's a mosquito breeding place on top of a slab, we may need a chemical larvicide, right? Okay, so like that. And when there's infected mosquitoes, we may need fogging. Okay, so rationally we have to decide the mosquito control methods, which is called integrated vector control. Okay, integrated vector control is the name that we use to tell the rational combination of mosquito control methods, right? Right. Then, so let's can you all confirm whether because the screen got paused, can you all see the screen again?
Yes, sir.
Okay, right. And then the OSCE, for the OSCEs, now they can ask anything on dengue, right? They can show you uh, the different methods and ask to name those, right? So like that, okay? So there's a problem with the sharing the slides. So can you all see the slides again? Just confirm.
Yes, sir.
Right, okay. And then rabies. Right, rabies. So Jalabhitikawa, right? Okay. So rabies, you should know that one thing that can be asked is on post-exposure therapy. Okay, when there's an animal bite, okay, we categorize that wound as minor or major, right? Then we see some characteristics whether the animal was healthy and vaccinated, or whether the animal is observable and or unobservable. Okay, so depending on that, we decide the post-exposure therapy method, right? And what you should know now is then even before that, okay, before that we have dog vaccinations. Now, this is post-exposure is for the person. Okay. Dog vaccination is for the dog. Now, what you should know is now we are vaccinating cats also. In our national government program also, now we are vaccinating cats, not only dogs. Okay. That you should know. And you should know like what are the places where post-exposure prophylaxis is available. So the answer is divisional hospitals and above currently having anti-rabies vaccines, right? Whereas secondary and tertiary institutions will definitely be having anti-rabies serum also, right? Okay, so we may use anti-rabies vaccine or anti-rabies vaccine and anti-rabies serum depending on these characteristics, right? So those things you should know, right? Then acute flaccid paralysis. Acute means sudden onset. Flaccid means less power. Okay, flaccid means less tone, right? Paralysis means less power. So the conditions that give rise to sudden onset, loss of tone and loss of power are called acute flaccid paralysis conditions. Okay. So examples of acute flaccid paralysis include polio, Guillain-Barré, transverse myelitis, like that. Okay. So when acute flaccid paralysis cases are reported less than 15 years, okay, those all acute flaccid paralysis cases should be informed, right? And there are certain investigations that are done. We get 2 stool samples from the patient, and then we get some 3 to 5 stool samples from the contacts, right? And then we do some follow-up. So this is when the age of the patient is less than 15. When the age of the patient is more than 15, when polio is suspected, we do these activities, right? So when it is less than 15, any diagnosis, acute flaccid paralysis, we do this. More than 15, when we are suspecting polio, we do this, right? And then TB. Regarding TB, what you should know is that there's a central program, okay, and there's a form called 816A. When the person is diagnosed as a TB patient by the district chest clinic, the relevant MOH area is notified by 816A form. And then the relevant MOH area fills back and sends something called 816B form, right? So what you should know is that these are done as online systems now. Okay, many of these systems are now online, right? Then if we move to food safety services, right, we have food handling establishment inspections and then grading of food handling establishments, right? Food sampling, right? Then services for household food safety and services for street vendor food. Now, if you see food handling establishments, right, we use a form called H800, right? H800 to grade food handling establishment, and we give a grade A, B, C, or D. And we ask the public to go for shops where either grade A or B is there. So those things we are covering in the OSCEs, right? And then food sampling, there are formal food samples and informal food samples. Now, how to get a formal food sample, right? Those things, usually those things are hot topics in OSCEs, right? Right. And then for the households, we give certain food related advices like cover the food, separate the raw food from the cooked food, heat the food heat the food well, right? Okay. So like that, I mean, there are certain advices we give. So those things also we are covering. And then street vended food. Okay. Veedi Kada is also a component that is coming under the scope of the MOH office. Okay. And under the food safety. Right. And then there's a form called H800 that we use to grade the food handling establishments. And there's a specific form which is used to grade the school canteens, right? That also will be covering in the OSCE sessions, right? And then when we say water pollution ill effects include drinking water scarcity, then loss of biodiversity, water-related diseases, accumulation of heavy metals, and eutrophication. So water-related diseases include water-borne diseases. That means the organism is spread with water, like typhoid, cholera, like that, right? And then water-washed diseases, where the disease is there when the water is not there, like scabies. Water-based, like schistosomiasis, where the life cycle, part of the life cycle of the agent is happening in the water. And the other type of water-related disease is called water-related vector-borne, where the agent does not need water, like the dengue, okay? But the vector, the mosquito needs water, okay? So likewise, water-related diseases can be categorized into four types: water-borne diseases, water-washed diseases, water-based diseases, and water-related vector-borne diseases, right? And then when the heavy metals are accumulated across the food chains, right, we get diseases. One example include Minamata disease that happens in Japan, right? Some time back. And then you may see the Bear Lake. Now we have those covered in our OSCEs where you see the Bear Lake is shown green in color, right? Why green? The process is called eutrophication. Happens because of high nitrogen and phosphorus and algae being developed on those, right? So those things like this, okay, in those keys. Now those can be asked, right? And then when you purify water at the household level, we should boil the water for 1 minute, non-turbid water, turbid water more than that, right? And we try to boil, we try to cool and store the water in the same container. Right, then you should know what are the features of a protected well, right? Those things are also asked. And then what are the steps that are happening in a drinking water treatment plant? There are 4 steps called aeration, sedimentation, filtration, and disinfection, right? Aeration is we add oxygen so that the harmful gases get evaporated, okay, get removed. Then sedimentation, we make the heavy particles settle. Filtration is we send the water through sand or charcoal, and disinfection is we add the disinfectant like ozone and chlorine. So in Sri Lanka, mostly it's the chlorine. Okay. So chlorine may come as solid form like calcium hypochlorite, liquid form like sodium hypochlorite, and gas or gas in liquid, right? So chlorine also a hot topic in OSCEs. Then when we get wastewater treatment processes, there are primary, secondary, and tertiary processes that we do. Right. In occupational health, you should know the difference between hazard and risk. Right? Hazard is where the potential of damage is there. Risk is where the probability of damage also there. For an example, let's say if there are acid, there is an acid. Okay, tube with acid, but hand is not below. So that means acid can cause damage. That is, potential of damage is there. So that means hazard is there. But since the hand is not here, risk is not there. But in the second example, acid is there. That means hazard is there. And since the hand is also there, the risk also there. Okay. Like, so if you apply this, now let's say there's a chemical factory. So that means hazard is there. If a house is also nearby, then the risk also there, right? Right. Then the hazards, we can categorize the hazards as physical hazards, chemical hazards, biological hazards, ergonomical hazards, psychological hazards, right? And these are there are examples, right? Physical hazards examples include too much noise, too much light, heat, pressure, radiation, like that, right? Chemical hazards include solvents, heavy metals, pesticides, dust, like that. Biologically, you know, that can cause diseases, right? Bacteria, virus, fungi. So like that, I mean, there are different hazards. Then there are different health effects due to these hazards, right? As an example, physical hazards may give also hearing loss, fatigue, okay, headache, falls, heat cramps, like that. Chemical can give rise to burns, cancer, allergies. Biological will give rise to communicable diseases, and then ergonomical. Ergonomical means when the worker is not matched with the environment, right? Repetitive movements, okay, awkward postures, those are examples of ergonomical hazards, right? They can give rise to musculoskeletal problems. And psychological hazards can give rise to stress, right? And then, like in the case where some diseases are notified to the MOH office, there are certain diseases and injuries that should be notified to the labor department. So those are called occupational injuries and occupational diseases, right? Examples include if there's a death that happened in occupational setting, should be notified to the labor department. if there's any condition that make a person disabled for more than 3 days, right? Should be notified. So like that, there are certain occupational injuries and diseases that should be notified to the labor department. So occupational diseases that should be notified include any disease that is assumed to be of occupational in origin, right? Right. And then regarding non-communicable diseases, right, we discuss about the well women clinic where the person is screened for, where the woman is screened for diabetes, hypertension, cervical abnormalities including cancer, and breast abnormalities including cancer. And for the well women clinics, we target 35 and 45-year women. And you know that for both women and men and women, we have something called healthy lifestyle centers. Okay, healthy lifestyle centers where we have two categories. Okay, category A people means who are apparently healthy 35 years or above. Category B means between 20 to 34 years with some risk factor. Okay, so they can go to clinics called healthy lifestyle clinics, right? So in the healthy lifestyle clinic, certain services are given, history, examination, investigation. Certain investigations are free, like total cholesterol. Okay, so I mean more investigations than the well-being clinic are done, right? And then finally, the risk level of the person is categorized with a color code system by WHO ISH risk CVD risk prediction charts. Okay, so every person is allocated a color, right? Considering all the factors. So depending on the color, the management protocol is decided, right? How to follow the patient up, right? Then waste management, you should know that for general waste, there are colors that we use, biodegradable waste in green, glass in red, right? And then plastic or polythene in orange, then paper in blue, and then metal in brown, right? And then infectious waste, we have a similar, but I mean more additional colors like sharps. We put in sharps containers, sharps bins where there's yellow color with a red strip, right? Right, and 5S system, you know that this is a Japanese system to increase productivity. There are 5 steps. Okay, so those we'll be covering in this session. So you know that keeping things in order, and then I mean sorting, then keeping things in order, then cleaning, and then having some norms, standardizing, and then taking measures for sustainability. So those are the 5S's, right? And then some regarding building constructions, right? There are certain minimum standards that we will be discussing, right? Okay. So like, I mean, if you get some legal documents, right, in certain settings, when there's a plan of a building, right, plan of a house, there's a minimum height, okay, minimum area, minimum width of the room, right, minimum area of the windows, that those are there that we'll be discussing, right? Okay. And then when we move to the other topics, like then you should know that health system, we can talk about 3 types of services: primary healthcare services, secondary healthcare services, tertiary healthcare services. So primary healthcare services are the services that should be available, accessible, and affordable to all people at all times. So these are certain examples of those, right? Treatment of common diseases, treatment of common injuries, antenatal care, vaccination, family planning, like that. We have discussed these. And then these services, some are given by curative sector and many are given by preventive sector, right? So we have MOH officers to give those preventive sector services, right? And we have discussed that MOH office is divided into public health midwife areas and public health inspector areas, and the MOH office is in the middle. And we have clinics and the center and clinics in the all PHM areas, which are called field clinics. Central clinic is functioning on Saturdays for working mothers and also the mothers who miss the field clinics, right? And then depending on the types of services that are given in the clinics, we can categorize them as single clinics, combined clinics, or polyclinics, right? And every public health midwife is having an office, and every public health inspector also having an office, right? And we know that there are population norms, like we like to have one public health midwife for 3,000 people. We like to have one public health inspector for 10,000 people. We like to have one MOH office for 60,000 people, right? And for that 60,000, we like to have 2 doctors. So for every additional 30,000 of doctors, we like to have one additional doctor, right? And in these MOH officers, the head of the institution is called the MOH, and all other doctors are called additional MOHs, right? Okay, and then we can divide the Sri Lankan public health system into 4 levels: national level, provincial level, district level, and divisional level. At the national level, we call the central level or national level, right? And then provincial level, we have PDHS officers, provincial director of health service officers, right? So every province is having a PDHS office. Every district is having a regional director of health services office, RDHS office. The only exception is Ampara districts where there are 2 RDHS areas, Kalmuni and Ampara, right? All other districts are having 1 RDHS area, right? And then MOH areas are there. We know we have discussed that around 360 MOH areas are there, right? Okay, and some certain exceptional areas are there, like Colombo Municipal Council area, okay, Kalutara NIHS area. So those we will be discussing in the sessions, right? So at the central level, we have the Ministry of Health, where there's a Minister, Secretary of Health, Director General of Health Services, and there are Deputy Director Generals, and under them there are national level institutions, right? And at the provincial level, we have the PDHS office, and there are consultants and other doctors and other staff members. So at the district level, we have the Regional Director of Health Services, and consultants are there, other doctors are there, other staff members are there, right? Okay. Then the levels of prevention. We categorize the levels of prevention into 4: primordial prevention, primary prevention, secondary prevention, and tertiary prevention. Primordial and primary prevention are told to be at the pre-pathogenesis phase. Secondary and tertiary are said to be at the pathogenesis phase, right? What is primordial prevention? That we are, if we get a certain condition, like let's say the condition is hypertension. Okay. So what are the risk factors for hypertension? Let's say obesity, smoking, alcohol, those are risk factors for hypertension, right? If we want to prevent those risk factors at the community level, that is called primordial prevention. So having these pictorial warnings, having walking pathways, those are primordial prevention for hypertension. And then primary prevention means a person preventing that one getting the disease. Okay, so a person doing exercises, a person not smoking are examples of primary prevention, right? Secondary prevention is the person has got the disease. So preventing complications, minimizing complication is the aim of secondary prevention. So to do that, you need to identify early, treat early, refer early. So a person with hypertension getting the blood pressure screened, getting antihypertensive treatment, those are examples of secondary prevention, right? When the secondary prevention fails, you get complications. Like let's say hypertension is more and then the person was a stroke. Okay, so there's disability now. Okay, so minimizing disability is an example of tertiary prevention. Okay, so rehabilitation is an example of tertiary prevention. So under rehabilitation, you can talk about physical rehabilitation, psychological rehabilitation, vocational rehabilitation, and social rehabilitation, right? Then cause of death. You know, when we have a cause of death, we have something called the immediate cause. Okay, and there's an underlying cause. Underlying cause is the one that initiated the chain of events. Okay, so for public health, we are more worried about the underlying cause. We want to see what is the underlying cause. Like let's say there's a person with peptic ulcer disease who got it perforated and then there was a peritonitis and died. Immediate cause is peritonitis, underlying cause is peptic ulcer disease. There's someone with ischemic heart disease who got the plaque ruptured, then there's a thrombus infarction, and then there's a septal rupture. So septal rupture is the immediate cause. Ischemic heart disease is the underlying cause, right? And there may be some other causes that are not in this direct pathway but would have contributed to this. Those are called contributory causes, right? So they may give a death certificate and they may ask what are the errors in this death certificate, right? Cause of death errors. One common error is, especially these intern medical officers, they write cardiorespiratory arrest as the immediate cause, right? Never write cardiorespiratory arrest as the immediate cause. Cardiorespiratory arrest means no heartbeat, no respiration. Those are not the causes of death. Those are, features of death, right? When we want to decide whether the person is dead or not, we may see whether there's pulse, whether there's respiration, whether pupils are fixed and dilated, not unresponsive, right? So like that, those are things that we examine to diagnose whether someone is dead or not. Those are not the causes of death. So never write cardiopulmonary arrest as the immediate cause of death, right? Then when we say demography, there are demographic processes, fertility measures, mortality measures, and migration methods. So you should know what are the difference of these crude birth rate, general fertility rate, age-specific fertility rate, total fertility rate, gross reproduction rate, net reproduction rate. Then under mortality, crude death rate, age-specific death rate, cause-specific death rate, case-fatality rate, neonatal mortality rate, infant mortality rate, maternal mortality ratio, perinatal mortality rate. Immigration rate, emigration rate, net migration rate, population change, natural increase, population growth rate. So this formula and all you should know. So we have done those also for theory, and then in the next sessions also those are there as OSCEs, right? And then this is another, hot area where population pyramid may be shown as a OSCE station, right? So, population pyramid is a graphical representation of the population, right? We have the age groups in the y-axis and the population in the x-axis, right? When the x-axis is wider, that means more people are there. So usually Sri Lankan population pyramid, female side is wider than the male side. Why? More females are there, right? So like that you should know. Then another area that may come as single best answer questions or skis or whatever is the demographic transitional theory. When we get an area, usually at the first stage, births and deaths both are high. Then what happens with development? Deaths go down and then births go down. Then both become low, right? This transition is called demographic transition theory. From a high birth rate and death rate setting, having a transition for a low birth rate and death rate is called demographic transitional theory, right? So Sri Lanka is closer to growth stage 4, right? Okay, so you should know, and many of the developing countries are in the stage 1. So why stage 1? You see, developing countries, births are more, that means family planning practices are less, and deaths are more, that means life expectancy at birth is low, right? Whereas in developed countries, crude death rate also low. Why? The life expectancy is high, right? Health services are more, and crude birth rate also low. Why? There's more family planning practices, right? Okay. Then you should know this screening, right? When you are having a screening test, okay, we compare that with a diagnostic test, right? And we have the findings in a 2 by 2 table and calculate something called sensitivity, specificity, positive predictive value, and negative predictive value, right? So if they give a table, you should be able to calculate the sensitivity, specificity, positive predictive value, negative predictive value. We have done those, right? And then basic statistics. I mean, you can't get a chance. No, you should be. I mean, any potential area that can be asking in a OSCE station, you should be thorough, right? So variables can be categorized as categorical and numerical ones can be further categorized as discrete and continuous. So in OSCE station, if they tell some list of items, list of variables, like let's say gender of a person, BMI level, heart rate. Then if they ask you to categorize them into categorical, numerical, discrete, and numerical continuous, you should know, right? So things like the gender, sex, blood group, okay, the residence, the district, province, those that the response you select from a category are called categorical, right? Where you express as a number without decimal points, numerical discrete. With potential decimal points, numerical continuous, right? And then there are 4 scales: nominal, ordinal, interval, ratio. Nominal scale means based on a feature, we are dividing into groups. Ordinal means we are giving a rank, higher or lower. Interval and ratio means we can say how much higher, how much lower, but the difference is that in ratio scales, there's an absolute 0. In interval scale, there's no absolute 0, right? So again, the maximum information you can tell from nominal scale is to which group this person belongs. Ordinal scale, you can say whether someone is higher than or lower than another. Interval scale, you can say someone is how much higher, how much lower, but you cannot say how many times higher, how many times lower. In ratio scale, you can say how many times higher and how many times lower, right? So if I again tell, ordinal scale is associated with ranking, ratio scale is associated with an absolute 0. Interval scale, there's no absolute 0, right? Nominal scale, based on a feature, we are dividing into groups, right? So those things you should know. And then if you just summarize statistics, you can have descriptive statistics and inferential statistics. Descriptive statistics is where you describe the whole group, right? With numerical methods and non-numerical methods. Non-numerical methods include tables and graphs. And under the graphs, there's a particular graph called normal curve. Okay, that you should know. Features of the normal curve. Symmetrical, inverted bell-shaped, more values in the middle, less values in the peripheries, right? And then ends are expected to be touching the x-axis at infinity. And the area under the curve can be described using standard deviations. Between plus or minus 1 standard deviation, 68%, plus or minus 2 standard deviation, 95%, plus or minus 3 standard deviation, 99%, right? And numerical methods include measures of location, which are either the measures of center or other locations. Measures of center include mean, median, mode. Other measures include quartile, decile, centile as examples. And there are measures of dispersion, right? Range, interquartile range, mean deviation, standard deviation, variance, coefficients of variation, all we have done, just go through those, right? So when we can describe the whole group, we can use descriptive statistics. When we can't describe the whole group, we get a sample, and from the sample, we like to get a value for the population. Then those techniques are called inferential statistics, right? So under the when you use inferential statistics, you get a sample. So there are sampling methods. Probability sampling methods like simple random sampling, systematic sampling, stratified sampling, cluster sampling, okay, and non-probability methods, right? And then when we have two groups, when there's a difference, the difference can be due to an error, chance, or a true difference, right? To see whether that is due to a chance or true difference, we use statistical methods, which can be either confidence intervals or statistical tests. You need to have some idea about statistical test. If they give a scenario, there are two votes, vote 1 and vote 2. You are comparing the proportion of people who died with dengue. Dengue proportions. Two groups, categorical variables. Then you should know it should be chi-square test or Z test for proportion. And you are comparing two groups, duration of stay, which is a numerical variable. So two groups, numerical variable. Either Z test for mean or independent sample T test. Like that, some slight idea about the statistical test also better to have, right? So like that, anyhow, we will be covering them in the OSCE station. So now, when you have that idea, right? I mean, when you cover this scope, right? You will feel confident, right? That is why the aim of this orientation was to open your eyes, to be an eye opener on the potential areas the questions may come, right? And in the next sessions, what we are doing is going to deeper and discussing more finer areas, right? Okay, and discussing around the topic so that you will feel confident when you are going to the exam, right? Okay, if I summarize again our plan. So this was the orientation session that was supposed to, like, give you kind of a refresher on all possible areas where the questions may come, right? And in the session 2, can you all see the slides? Just confirm whether you all can see the slide on session plan.
Yes, sir.
Okay, so this is the first session where we had an orientation. Then in the second session, so we'll be having specific questions. Now you see that, I mean, this session we just refresh. But from the next sessions, it will be like the real stations, right? So those will be station-based questions, right? So like this, there will be a station and then a particular question is asked, right? Okay, so then second session will be on maternal and child health services. Third session on disease control, environmental and occupational health related services. Then fourth session on other topics. Fifth session will be targeting communication skills where you need, where you are expected to talk, right? And then last session we'll be doing these recent changes and some timely topics like this disaster related questions. Okay, and any changes that would be done in the next few weeks, and also the changes that would have been done in the last few months. Okay, that you should know. Always remember, you are questions on the current practice, right? If you are asked what are the eligibility criteria for LRT, You need not tell that in 2022 it was like that, now it is like that. You have to tell current practice. You just tell the updated answer, right? That is why it is important to update the knowledge, right? Unlike in other subjects, community medicine, everything is frequently changing. That is why in all the sessions, we are having a final session to discuss the changes, recent changes, right? And some timely topics. Okay, I hope that you all got an idea, right? Then get the maximum. Anyhow, this session also will be put into the system. You can go through this session also. And from the next sessions, like, I mean, as I told, there will be a written template, right? So you get the template and go through the questions and have the answers ready, and then go through the discussion, right? That we are going to discuss the questions, right? So today it was an eye opener that you all just listened and I just talked. But from the next sessions, you do the homework, you go through the stations and write the answers, okay? And then the discussion will be there on the answers, right? Using like relevant circulars and then theoretical infos like that, okay? Okay, then have a great day, right? Okay, get the maximum out of these sessions.